women and pregnant people or new parents report afterwards that they were not listened to, and that they did articulate that there was this wrong, or they felt this, or they felt the other, or that they were refusing something and they were not listened to. And that's the most common thing that people say afterwards, is they say, it's not that I got bad care, it's that I wasn't listened to, that I wasn't treated with dignity and respect. And those are the key issues.
It is gender bias. Hello and welcome back to The Mothership, the show that brings the issues that matter most to Irish families to the table. I'm Laura Cunningham, and on this week's show we're talking about the gender imbalance in Irish healthcare. Irish women are currently fighting for change in areas like maternity restrictions and the ongoing issues around access to abortion, but there's a long history of imbalance in Irish healthcare. Joining us today is Aoife from Hyperemesis Ireland, Alana Ryan from the National Women's Council of Ireland, and Krysia Lynch from AIMS, which of course is the Association for the Improvement of Maternity Services in Ireland. Guys, thank you so much for coming in to us today. So we could probably dedicate a whole show to each of the topics that we're going to cover today, such as the level of stuff there is to unpack around them. But something that's on a lot of people's lips at the moment, Aoife, is the issue around medication that lots of women need during their pregnancy that's not covered under the drug scheme. So they're spending a small fortune on this drug that they really can't do without. So for the uninitiated, can you tell us what's going on there and why it's such a big deal?
Yeah, so hyperemesis is a condition of pregnancy. It affects about 1 to 2% of women who are pregnant, and it causes severe nausea and vomiting in pregnancy. So a little bit of nausea and vomiting is normal in pregnancy. This would be vomiting 20 times a day, unable to keep anything down, unable to function, unable to tolerate fluids. Not surprisingly, these women need medication to function through the day. And I'm a GP, I work with Hyperemesis Ireland, which is a charity that supports women with hyperemesis. And one of the things we've been working on over the past year is that Caraban is one of the medications that the Irish Institute of Obstetricians and Gynecologists recommends. It's first line, which means if you go to hospital suffering from hyperemesis, the doctors will put you on that. And unfortunately, it is not reimbursed in Ireland, which means if you have a medical card, you can't get it on the medical card, and it's not available on the drug payment scheme either.
And why is that?
So the honest answer is we don't know. Caraban, it's a trade name for pyridoxine doxylamine. So there are other trade names, but unfortunately they're not available in Ireland. So Caraban is the only one that's available in Ireland. It's not licensed, so therefore the government is saying that it shouldn't be reimbursed. However, we would say if the national guidelines are recommending it as first line, then it should be reimbursed. And it costs about €45 per week. So if you multiply that by 40, it's not insignificant, especially during the pandemic when some women haven't been able to work. It's a big chunk of their weekly amount to spend on medication. I suppose I'd also say, and this is not to minimise these conditions, but things like Viagra is available, it's fully reimbursed. Things like minoxidil, which is a drug for male pattern baldness, and this is not to minimise these conditions, but I suppose our query is, if they're reimbursed, why on earth is this not reimbursed?
How are they vital when this medication is not?
I think they all should be reimbursed.
Of course,
But I wonder why, and it's no secret the past 4 ministers for health since 2011 have been male, so none of them have had hyperemesis. It's a query we would like. So part of our campaign is to make this issue known, and then ideally to make it reimbursable.
Yeah. So what needs to happen now for that to happen?
Well, the HSE over the past few days have come out with a vague statement saying that they will do a patient-specific thing for it, a financial aid, but we don't have any more details at the moment. So that would be great. Yeah, that would be great. I mean, there's also a medication called PrEP, pre-exposure prophylaxis, for men who have sex with men. If they want to go out and have sex with somebody and they don't want to get HIV, or if they have a HIV positive partner, they will take this. That's reimbursable on the medication. So I suppose,
and so it should be,
yeah, and so it should be exactly like, obviously the government is taking sexual health seriously. That's great.
Which is not women's health?
Not women's health and not pregnancy health. So obviously it needs to change.
And is there anything that, the public can do about it? Because obviously everyone's really angry about it.
Yeah, so we have a Twitter campaign. It's HG2Costly, and you can see that. And then our website is hyperemesisireland.ie. We also have a peer support for women who actually are suffering from hyperemesis, and our contact details are on that, and women can contact us on that.
Okay, we'll leave all of the information below this video, so that. Krysia, I'm going to come to you.
And Laura, actually, I just wanted to say a few things about hyperemesis as well. And that is that hyperemesis doesn't just afflict a woman in isolation. It happens within the woman's own milieu. So that means that there's loads of things that we do as women day to day. We look after other children. We often maintain issues surrounding our home and our living space. And sometimes, if you're debilitated yourself, you're going to incur extra payments in order to get somebody else to mind your older children, perhaps, or somebody else to help you with cleaning at home. So these are extra payments that women who are in this situation are going to also have to make. So if you add that, in addition to payment for the drugs, you're looking at quite a large expenditure.
And of course, having a baby is expensive.
I couldn't agree more.
Yeah,
and not everybody is paid maternity leave. So, you know, we would say cost should not be a barrier to care.
No, because I mean, not everyone has kids, but everyone was a kid at some stage. You know, somebody has to do this. So it just can't be prohibitive, you know, anymore. It's just not, it's really not good enough.
And of course, Laura, there are other aspects of maternity care which are not funded. So the one that perhaps many of the people watching today will be familiar with is fertility care. We are the only EU country that does not have a publicly funded fertility care programme. So that means that people are spending anything from €5,000 up to €21,000 to try and become pregnant in the first place. And we know that about 1 in 6 people are going to be affected by infertility in some shape, size or form.
Because it's my understanding that in most parts of the UK, depending on where you are probably entitled to 1 round of IVF if you're struggling. But I think that shocks people here. They think, wow, that's amazing, but maybe that should be the way, you know?
Absolutely.
On the topic of pregnancy, I think there's a bit of a misconception at the moment that because many of the COVID restrictions have been lifted, that maternity restrictions have also been lifted. But of course, we know that that's not the case. Where are we at with that?
No, we're kind of in a similar situation to what we were several months back. I think that one of the most important things to mention is that there's huge variability. So there's huge variability with respect to what restrictions people are going to encounter. And, you know, variability within maternity services, within access to maternity care has always been a difficult feature of our maternity services. So we tend to find that in certain areas people have access to more choice, they have access to more different pathways to care, and now they have access to varying restrictions. So individual kind of fiefdoms or individual controls in individual hospitals are never particularly helpful. And women don't like that. They want to feel that if I live in Donegal, I have the same access as if I live in central Dublin. So what we're encountering at the moment is that we have a lot of changes have occurred with respect to postnatal visiting. So we have greater postnatal visiting. But just to give you an example, you have unlimited postnatal visiting in the National Maternity Hospital, irrespective of whether you're a public patient, semi-private or private patient. Whereas if you go into some of the regional hospitals, and I'm not going to name them, you might only have postnatal visiting of 1 to 2, maybe 3 hours, because that is the bare minimum that is covered under the standards. So we do have variability there, but that's, you know, that has been accommodated to a certain degree. People are accompanied once they get into an individual birthing room. And then everything that happens before that is really still much the same as it ever was. So people are attending antenatal appointments on their own. And that is extremely difficult because antenatal, the work of the antenatal period is to set yourself in motion, to not be too fearful, to understand what's going on, to plan for the rest of not just the pregnancy, but for becoming a mother as well. So if you're going in alone, you're going to be told various things. You're going to be told about various conditions. You're going to be told about various risks. And you're on your own. You're receiving that, not really sure of what's being said. You've no one to reflect back for you. You've no advocate. And that's a really big thing. You've no one else to speak for you. And then most of the time, thank God, people are getting really good news. They're being told that their babies are growing well. You know, they're getting a scan and people are coming in for scans. But often there may be news that is questionable. And that still means the pregnancy is continuing, but there might be a question surrounding gestational diabetes, or there might be a question surrounding blood pressure, or there may be a need for an in-hospital stay. But sometimes people are getting really unwished for news, and that is that their baby is not viable, that the pregnancy is not going to be able to continue, that perhaps they're encountering a loss. And we have so many reports of people still to this day that are hearing that news on their own.
It's just awful.
You know, it's awful. And people who are coming in with some indication that things are not right. You know, the classic indication would be that there maybe is some bleeding or there's contractions when there shouldn't be contractions. So people already know this isn't good.
They're terrified.
And they're terrified. And they're coming in and There is nobody with them. I heard just from one of the big Dublin maternity hospitals the other day that a woman who had suffered an early loss was left for 5 hours before her partner was permitted to enter. And, that is just not acceptable on a human level, never mind anything else. And then we have the situation when people are being induced. We have quite high induction rates at the moment. So, for example, the indication at the moment is if someone has had COVID during their pregnancy, there is a general understanding that it's ideal for the pregnancy not to continue for too long past a due date. So sometimes that's going to mean induction, and the rates have been higher in the last couple of years than they have been before. And when people are induced, they're induced on an antenatal ward. And for that early part of the induction, for the most part, they're alone.
I have a pandemic baby myself, and I was induced, and I laboured. I was in the whole process, which is not a nice one, as anyone who's been induced knows. And I laboured all alone until the very last minute, really, when I had an emergency section. And I thought that those days were gone, because that was in the height of it all. I spent 5 days completely alone in the hospital, which was fine. I'm very privileged. I had my own room, and I was fine. But that's for me. All of my antenatal appointments are positive news. I was still terrified. So I can only imagine how it must feel for people when it's not.
And I think one of the key mistakes that was made very early on was that we considered partners as being separate
visitors.
They were visitors. Now, if you're going to visit, your Auntie Mary with a bunch of grapes and she's had appendicitis and she's recovering, you're a visitor. And, no disrespect to Auntie Mary. I'm sure she'd love to see you. But, you are a visitor. Whereas when it's your partner that's going through the labouring process, especially on an induction, which, can be difficult and which can be, uncomfortable for people, your partner is your pain relief mechanism. You're not going to get an epidural in an antenatal ward, and you're not going to get gas and air in many antenatal wards. No. So having your partner there with you to keep you physically going and also to keep you mentally and emotionally going is absolutely vital, and those restrictions are still in place.
So, we're hearing, every time Stephen Donnelly speaks about this, he says that he has advised the hospitals of the various, recommendations. Why are hospitals not obliged to follow the government's advice?
Well, it's an interesting thing, isn't it? Because we have 19 maternity units, and we have some of those maternity units are dedicated maternity hospitals. So, for example, CUMH in Cork, the Coombe in Dublin, and Limerick Maternity Hospital. Those are just examples. There are others. Yeah. So whilst larger dedicated maternity hospitals can put the restrictions to bed, the smaller units are also general hospitals. Yeah. So they will have a unit that maybe has a couple of beds dedicated to maternity, but they will also have everything else going on. And some of them are acute hospitals as well. So it is more difficult. But having said that, what the pandemic has showed us is it's showed us an utter lack of investment in our maternity services, absolutely, in maternity care in general, despite a maternity strategy that came on board in 2015-16. And what we really need is we need capital investment, we need resource investment, and we need human investment in our maternity services so that everybody, irrespective of where they live, will have access to the best quality maternity care.
And are these restrictions in place in non-maternity settings? Or it seems to be that it's just super strict in maternity?
I think that there are visiting restrictions in place across the board. If your viewers go onto the HSE website, they can see restrictions across the board, county by county by county, in every single hospital. So there are restrictions across the board, and they are in effect. And people are still following and abiding those. However, they don't have that same kind of impact on somebody who's gone into hospital. My own husband was in Vincent's, for example, and he was in there for 5 days, and I didn't get to see him at all. Okay. But I knew he'd be okay, and I was able to speak to him. He wasn't having a baby,
no.
And I wasn't necessary to help him through every step of the way. And I think that's why people feel it so keenly. And I think it's also really important to say that it's not just for people who are having the happy news of a healthy, well baby. There are also real issues associated with the restrictions with respect to NICU visiting, neonatal intensive care unit visiting. And, in some units, partners are not getting access. And there are real issues as well with respect to people who are suffering loss all the way through pregnancy. And just, your viewers may be interested that the HSE is actually going to be conducting a huge review of loss and bereavement in pregnancy. So do look out for that.
Yeah, absolutely. Another issue I think that people may feel has been resolved is the issues around abortion access. So we repealed the 8th Amendment, Alana, but really what we did was just kind of open a small window of opportunity for people to avail of necessary medical care, and it's not enough. Is that right? Can you talk us through that a bit?
Yeah, so we're now 3 years into the rollout of abortion services, and so they're available on request up to 12 weeks, and then after 12 weeks in specific circumstances. So in the case of fetal abnormalities, or in the case of a severe risk to the health of the mother. Now, obviously, there's a real challenge there in terms of the provision, because ultimately, at the moment, only 1 in 10 GPs are providing in the community, and only 10 out of 19 of our maternity hospitals are providing care in that setting.
So have they decided they've objected to this? Is that essentially what's happening?
I think it's a mix of reasons, you know, and I think we do need to take the time during this 3-year review of the operation of the legislation to listen to providers and think about the concerns they have. But I really think the point we need to remember is that the continued absence of provision is having real and direct consequences on service users. And the reality is that there are very tangible, simple measures we could take to bring more providers on board, and we're not seeing that progress swiftly enough. So, for example, we were told that the introduction of safe access zones would be a really important measure to give GPs the confidence to be able to provide the service, to know that they are protected from harassment or abuse, and that their service users and the community as a whole is. But 3 years on, despite that initial promise in 2018 that the legislation would be accompanied by safe access zones, we're only just seeing it now on the spring legislative programme. And it's taken a campaign group in Limerick, Together for Safety, who have organised in their spare time, working with cross-party parliamentarians to actually get the bill to this point. And, really, these are women who are organising in their communities and bringing about the change that we shouldn't have to push for. This is a core way that we can bring care closer to home and to ensure that people aren't travelling those terrible distances.
There are some troubling stats around women still travelling to the UK. Can you talk us through those?
And I think it's a really key point that was made earlier in the discussion around the devastating news that people are receiving in hospitals, because we know that care in the case of fetal anomalies is particularly challenging in Ireland. So not only are these women receiving difficult news, often on their own because of these restrictions that are ongoing in the maternity hospitals, often they're told that their situation isn't fatal enough to qualify for care in Ireland. And that's because in the legislation there's a 28-day clause. So the doctors have to be absolutely certain that that fetus will not survive beyond 28 days. And understandably, these conditions aren't black and white. It's very difficult for medical practitioners to say with the level of certainty that's required of them that the child won't last beyond 28 days. And it's devastating for the practitioners who want to provide that care for the women.
Of course.
But the reality is that those women, when they receive that diagnosis, many are still travelling to the UK and to other European countries. And we've seen actually, since 2018, a significant increase in the proportion who are travelling on those grounds. So it was initially around 3% of all Irish residents who travelled to the UK, and now it's at about 30%. On the grounds of fetal anomalies. So we can really see that aspect of the legislation particularly doesn't seem to be working in practice.
No. You mentioned the review that's going on, and there's a public consultation as part of that. Can you explain that to anyone who doesn't know about it?
Absolutely. So we're now into the 3-year review of the operation of the legislation, and that's really a chance for all of us to re-energise, reorganise and to be active to ensure that the women and pregnant people in our communities are receiving the care they need. So there is a public consultation. It launched in December and it will close on the 1st of April. And you don't have to have direct experience of abortion care. You can submit based on providing support to somebody who has had that experience. Maybe you provided childcare, maybe you gave money to support. Maybe you're just an ally and you're just concerned that actually maybe somebody I know will need this at some point in their life, or maybe I will need it at some point. And so it's a public consultation, which is actually quite simple. It just asks what's operated well and what's not operated well.
And people can submit their thoughts to that.
Absolutely.
Right, okay.
And at the National Women's Council, we're bringing out a quick guide next week, which will support your viewers and anyone in the general public to make that submission. Because the more submissions that we have and the more the government is made aware of these challenges that women and pregnant people continue to face in accessing the service, the stronger the chance we have of ensuring that those barriers, both in the legal framework and in the kind of community and hospital network, are addressed.
So we'll leave all the details of that again. So, I mean, that's great. It's a chance for us to put our voice to this campaign, maybe muster up some of that energy that we had when we were all campaigning for the 8 to be amended, and you get in there and give your opinion on it for sure.
Absolutely. And there is 2 other strands to the public consultation. So there's research with service users, which is being run out of Trinity College, and it's a really robust piece with about 50 women on their experiences of care since 2019. And we also know that there's just been a tender put out for research with service providers to hear what their needs are and what concerns they may have and how these could be addressed. Okay. So it's a really thorough review process, but the public consultation is a key aspect. And the more people who can submit and engage with it, the stronger the likelihood is that we can see those changes, both in terms of investment and supports to bring more providers on board, but also in terms of amendments to the black and white letter of the law, which are having the adverse impact.
Okay. So we need to shout about this from the rooftops and get everyone on board, really. Another thing related, well, it's all related really, isn't it, is the free contraception for women under the age of 25. I think we're all in agreement that the 25 number is a bit pulled from the air. It doesn't really make much sense, does it?
No, and I think, ultimately this is about ensuring that women can make a decision that's right for them around if or when to have children. And at the moment, the most effective forms of contraception, the long-acting reversible contraceptives, so the IUD and the IUS or the copper coil, these are all expensive, and that's a real significant barrier, particularly for women in disadvantaged communities who may have additional costs around, childcare, given the high cost of childcare in Ireland, who may have, health needs in the wider family, and who may be struggling to kind of meet the day-to-day living costs. So, we really need to be thinking about how this scheme can be extended so everyone can benefit and have a real choice around if or when to have children. Because when there isn't that universal free contraception, people use the cheapest forms, which we know aren't the most effective. And that really increases the risk of, being in a situation of unplanned pregnancy and the stress and the concern that can rise.
It's not easy to be a woman in this country. It's not. Sorry for calling.
And if you're over the threshold of a medical card, you have to pay for your IUD or your implant, and you also have to pay your GP to insert it. So that's a lot of money. And the other thing is that for most women who are having terminations, there was a worry from, men, that it would be all teenagers going for a teenage pregnancy. Actually, what we're finding is mostly it's women over the age of 25, even over the age of 30, who've actually completed their family, who are very definite they do not want another pregnancy. So it makes complete sense to extend contraception.
Yeah. And I think one of the things that we really have to bear in mind is that whilst we're talking about all of these issues from, women's perspective, there are huge intersectional issues here.
Yes, of course.
So, the marginalised people in our society are always going to be the worst affected. We have about 20% of people who are giving birth or are conceiving in Ireland are migrants who do not have a history of giving birth or family in Ireland. And for them, the challenges of going through pregnancy during COVID and of going through termination during COVID have been extreme. I mean, we have seen a lot of people who do not have an EU passport, who have been told that they will need to travel to the UK during COVID. And I mean, the difficulty that those people would have to have encountered with respect to visas, with respect to PCR tests, all of these things very expensive, almost impossible. We pretty much made it impossible for a sector of society.
But we
really
won't help you here either. You know?
And I think the other thing that's really important to say with everything that Alana has said is that a 21st century maternity care service includes contraception and includes full spectrum abortion care. Otherwise, it's not a 21st century maternity care service.
And for a community termination, you cannot access that if you don't have a PPS number. So if you're a refugee, forget it. You cannot access it.
Okay.
So, you know, that's another thing that needs to be amended.
Absolutely. And, you know, again, in terms of the provision in Northern Ireland at the moment and the situation there, you know, those women and pregnant people are continuing to travel to England for NHS free care, whereas it might suit them better to, you know, access care down south. But because of the PPS number requirement, they could face up to €450 for, you know, accessing that service here. And let's not forget there's a 3-day mandatory wait. So, you know, if you're having to arrange childcare, you'll have to stay overnight. And the World Health Organization has said very clearly that abortion is a time-sensitive procedure. There should not be any kind of mandatory waiting periods in legislation. And that's another issue we really need to raise in this public consultation.
It's just one barrier after the other, isn't it? Whether it's financial or time or, like you say, the whole plethora of other issues that come in place when you're not, you know, if you don't have an Irish passport.
And it's adding trauma to what are already really difficult issues. And, you know, the patients come to me and they're already traumatised from what's happened to them. And then they were like, and my partner couldn't be there, or and I couldn't avail of it in time. And it's just, it's layer upon layer.
And I think to some degree, you know, what we're touching on here as well is a system that is quite patriarchal. You know, I'm speaking primarily from a maternity care perspective. And what we see is that we see people who are not getting to voice their own autonomy, who are not getting the opportunity to give informed consent, and who are also, and this is the most important point, are not partners in their own care. And it's so important for us as women, or in terms of pregnant people, to be a partner in our own care. Because when we're involved and when our family are involved, it's then everybody working towards the same goal, and we're working with our healthcare providers, as opposed to feeling that we're left out in the cold, which I think a lot of people are feeling right now.
Yeah, we just so many examples of us not feeling like prioritised in healthcare. For example, the cervical check issue, I'm not even touching on the cervical check scandal, but just the constant delays. It seems to get pushed down the road when anything else happens. Obviously, breast check delays are a huge issue at the moment.
I have patients who are 52 who have yet to get their first breast check, and they might have a family history, and they're understandably worried.
Yeah, you know, I think people are campaigning now to have the age bracket brought down, but if you can't even get a mammogram when you're in your 50s or 60s, if you're high risk, then that just feels really like a long way off. It really does. Like, it personally affects me because I lost my mum to breast cancer, but that doesn't make me, you know, a candidate to go on the breast check register, which is madness, really.
And I have to say, you know, my mother had breast cancer, and she had it in the UK.
Okay.
And I supported people who got a breast cancer diagnosis here in Ireland. And, you know, we're talking about the NHS, we're not talking about private care in the UK. And the absolute difference in the way that the care, the diagnosis, and the approach was made is like black and white. I was really surprised. You know, in the UK 15, 20 years ago, we were already having situations where people were going in, they were getting the diagnosis on the day, there was no wait. When they were receiving care, they were receiving things on the NHS, like options to have aromatherapy, to have a hot stone therapy, to have a whole suite of complementary therapies that would help them relieve their stress. And we have a long way to go here. Long way
I
to
mean,
go.
I have like a friend of mine is having to pay for mental health services in connection with the pregnancy, which is just outrageous, like very expensive care for something that should be absolutely given.
Well, perinatal mental health was something, bizarrely, that was addressed post the National Maternity Strategy. You know, it was deemed to be so poorly available. So many hospitals and units in the land actually had no perinatal mental health care at all. So it has been addressed, but you're still finding that people are paying, you know, up to €200 for a half an hour consult. And that's quite expensive for people who really don't have that kind of money and who are not feeling well, within themselves. But I would like to say that we have fantastic perinatal mental health bereavement midwives and also mental health nurses within the maternity care services. And it has been a huge addition to the service to have psychologists and psychiatrists available to all pregnant people across the land.
Although
that was a
waiting
great
lists
move.
are an issue at the moment.
And also the absence of a mother and baby unit, you know, which is a really big gap in our provision in perinatal services. You know, that means that if you have severe mental illness antenatally or post-birth and you require the inpatient support in the post-birth period where it's so critical to have that early attachment and the mother-infant bonding, the current provision means that the mother is separated from her infant and there's no support for them to work together and have the kind of ongoing help of dedicated specialist staff. That mother is placed in a general adult psychiatric unit rather than being in a dedicated mother and baby unit, which we see in almost all other, well-developed countries' mental health services.
It's so traumatizing.
And the real irritating thing about that is, like, I was one of the people that represented service users on that, and we campaigned very heavily for that. And we brought it to the table, and it was considered, and it was rejected.
Wow.
And we even suggested, what about having pop-up mother and baby units, because that certainly would be possible. You know, using something like a HDU room, a high dependency unit room. If you know that you have a mother who is vulnerable at this point, you could just use that as a pop-up room, and that was also rejected. So it's difficult when you know that these things are so important, and yet there just doesn't seem to be the funding or the will to support them.
And these things are going to happen because perinatal psychosis is 1 in every 500 pregnancies. So it's guaranteed to happen to some women this year, and they may have no previous mental health issues or anything like that. And I think you're right. I think it's a systems thing. I think the individual staff, hospitals, everyone's doing their best, but representation matters unless there's enough women in government or saying that, look, these are issues that affect half the population. You know, it needs to change.
And then also, when these types of changes come about, it's really important that we campaign for them not to be in the primate city. And I don't mean Cork. I mean, we really need to have them in a regional basis. We need to make sure that if somebody has a psychosis in Donegal, that they're not being transported to a mum and baby unit in Vincent's. They need to be near their family. They might have other children, and that's so important. The whole point of a mother and baby unit is so that you'll have the other children maintaining contact. You'll be maintaining the family dynamic.
It's because these issues affect families. Obviously, they affect generally the woman first, but they affect the whole family. So as if our blood wasn't boiling enough, I have some very interesting stats here. So the Rotunda have done a report called Bias, Inequality in Women's Health and Research, and some of the figures that came out are pretty staggering. So as we know, it takes up to 9 years, actually 9 years on average, to be diagnosed with endometriosis in this country, which is shocking. It takes on average 2.5 years longer for a woman to be diagnosed with certain cancers than men. It takes, and this one is really bonkers, 7 minutes longer on average for CPR to be activated on a woman than a man, which is bizarre. And women are more likely to experience chronic pain, but they're more likely to be prescribed sedatives than painkillers, which really harks back to the whole hysterical woman thing, suffering on your nerves or whatever it is. And it begs the question, like, is it about being listened to? I mean, why do we think this is happening?
I think women are tough as well. I think a lot of us just kind of keep going, and hopefully it's getting better, and we are involving men. As you say, it's affecting families. So again, with hyperemesis, we would have partners come and say, I knew nothing about it until my partner had it. So hopefully it's getting a little bit better.
I think you're right. I think that women do put up with a lot of, we have a high, I'm not saying that it's higher than men, but we have a high tolerance. And I think to a certain degree, we have an expectation that it's not going to be that easy.
Yeah.
When I speak with a lot of people who have gone through the maternity services, and they've had very kind of almost unacceptable conditions along their journey. And they've just said, well, I just got on to it. I just got on with it. And, I just figured that there was probably someone who was worse off than me. I just got on with it. And people and women are incredibly versatile. We are incredibly versatile.
And we have to be, as we've seen.
And we're very responsive as well. We respond to changing situations, and we are willing to respond to that by putting ourselves on the line. And I think that happens a lot.
As depressing as it is to kind of lay it all out there like that, I think it is really important that people are aware that this is the issue, and for us to highlight it, because nothing will change unless we're kind of aware of this staggering imbalance when you really lay it all on the line. So like I say, I'm going to leave all of the information for the various campaigns and what people can do to add their voices and to have their say about all these things below the video.
Pleasure.
We've depressed the life out of ourselves, but listen, we're angry and we're doing something about it now. So, hopefully this is the start of change across the board, because something really needs to happen at this stage, doesn't it?
And so the Women's Health Action Plan will probably come out in another couple of weeks. Yeah. So they set up in the wake of the cervical scandal a Women's Health Task Force in the Department of Health with the HSE, and then with NWC as the critical friend. But we're now at the point where that's about to be published. So I think that a lot of these issues could be revisited again at the point where we have the report, because it kind of shows on a systemic level just how that pain minimization, the feelings of not being listened to or taken seriously, how that's coming through across the board, whether in the representative research or the research with the marginalized groups, and actions.
What you just said there, the being listened to, I think that's a massive factor actually.
I do think we should, because I feel like there are I completely agree that I think as women you probably do end up accommodating and also
have to.
Yeah.
We should not have to.
Yeah.
And I think that we see that a lot with respect to maternity, that women and pregnant people or new parents report afterwards that they were not listened to, and that they did articulate that there was this wrong, or they felt this, or they felt the other, or that they were refusing something and they were not listened to. And that's the most common thing that people say afterwards, is they say, it's not that I got bad care, it's that I wasn't listened to, that I wasn't treated with dignity and respect. And those are the key issues.
It is gender bias, I think, and particularly I worked on the marginalised women's research project, and if you're a young disabled woman, the experiences that were shared really suggest that there's a bias there in relation to not only you as a woman, but you as a younger woman, and then a woman who's disabled as well. And similarly, if you're a traveller woman or a woman of minority ethnicity, the stories that were shared suggest that there is this, lack of listening to and taking seriously the concerns. And, obviously, as a white middle class woman, I haven't experienced that as much, but I do think that there's, a real concern there in that so many women, particularly those from marginalised communities, are reporting that their voices weren't
as you
heard.
strip away those various different layers of privilege that we all have, it gets worse and worse. So, I think that's probably a really good kind of takeaway from everything we've talked about now, is that if you are a woman and you're, in medical care and you feel like it's not good enough or you're not getting what you need, that maybe it's not just you. And maybe you shouldn't just get on with it and suck it up. Maybe you should object and be angry and just tell people it's not good enough. So, because we've done too much of that, I think, over the years, haven't we? So guys, thank you so much again for joining us. We could have talked about this all day, obviously, such is the level of it that there is to unpack, but we'll leave it there. Thank you so much, and join us next week.